Assalamu alaikum, Dr. Amer. Sorry for the delay. I was having some connection problems. If we say we'll inshallah start in about 5 minutes, just so we can let everyone join, would that be okay?
Yeah, sounds good. Assalamu alaikum.
So, Dr. Amer, are you okay to start? And then as the meeting goes on, I'll just keep on adding people like we did before.
Yeah, that's fine.
Great. So, Assalamu alaikum, everyone. Alhamdulillah, we're back with Dr. Amer. He's the Associate Trauma Medical Director and Director of Emergency Medicine at St. Vincent Mercy Hospital in Toledo, Ohio. And today we're just going to be talking about controlling hemorrhage. So, yeah, take it away. Thank you so much for coming.
All right, Assalamu alaikum. Thank you for having me. Hopefully everyone can hear me well. If there's any issues, just let me know. I wanted to give a short lecture on just some concepts about controlling hemorrhage. So hopefully the objectives of this talk, I'm going to review the classifications of hemorrhagic shock, review this concept of circulation before airway or C before A for trauma resuscitation. We talked a little bit about this during the ATLS primary survey lecture, but hopefully just kind of review those concepts, discuss concepts of hemorrhage control in hospital, and then discuss concepts of pre-hospital care or public education. And that's kind of the, I think, focus of this talk. Um, and hopefully will be beneficial. So to start, when we look at hemorrhagic shock, hopefully, you guys have seen this table before, but when we talk about hemorrhagic shock, there's four classifications in increasing severity of hemorrhagic shock. When we talk about class one, this is less than 15% of blood volume loss. You don't see much changes in the patient's vital signs. So less than 100, blood pressure usually is normal, pulse pressure is normal, respiratory rate is normal. They may be slightly anxious. If you're measuring urine output, that's normal. Class two, now you're entering into 15 to 30% of blood loss. You may see some very slight tachycardia, but blood pressure is still normal. The patient is still compensated. But here you'll notice their pulse pressure is decreased. So the systolic and diastolic is more narrowed, it's closer. Um, Respiratory rate essentially would be normal and again, mildly anxious. Uh, but if you see 15 to 30% of blood volume loss, that's pretty significant. If you see the next stage, class three, and this is what you must recognize. I would argue you have to learn how to recognize in your training, especially if you're doing surgery, you have to be able to recognize class 2 hemorrhagic shock. But as a medical student, class 3 hemorrhagic shock is something you absolutely need to be able to recognize. And that's when the patient's lost 30 to 40% of their blood volume, their blood pressure is decreased, like they have hypotension. So if you have a patient that sustained a trauma that's bleeding and they have hypotension, they have at least class 3 hemorrhagic shock. They've already lost 30 to 40% of their blood volume. That's very significant. So these patients are tachycardic, they have hypotension, they're tachypnic. You have to recognize these patients immediately because this is where you have to act on it very quickly. Class 4 hemorrhagic shock, now you've lost over 40% of your blood volume. You have a crashing patient. This patient's crashing at this point. And it's when we look at this, so if you have a patient that's in class 1 or class 2, their blood pressure is okay, you can maybe treat this patient with a little bit of IV fluids like crystalloid, and they may be okay as long as the bleeding is not continuous. But if the bleeding is continuous, they're going to move on to class 3 hemorrhagic shock. At this point, the patient is hypotensive. This patient needs blood and needs it quickly, and then needs control of this hemorrhage. Otherwise, they're going to die. So if you're going to do any trauma or any surgery, you really have to have this chart always in your mind. The other concept I wanted to teach you guys was this concept of shock index. And if anybody's heard this before, put a message in the chat. But basically, shock index it's a good tool to keep in the back of your mind. It's basically heart rate, the patient's heart rate over their systolic blood pressure. And that ratio is the shock index. So if the shock index is greater than 1, that should signal alarms in your mind that something bad is happening. Like, for example, let's say somebody's heart rate is 120 and their systolic blood pressure is 90. This is a shock index greater than 1, right? This, a red flag should be going off in your mind because something's going on with this patient, something bad. And there's a lot of literature that shows patients with shock index greater than 1, they need more blood. There's a higher likelihood of needing an operation. And obviously, if you don't do anything, something, a bad outcome is going to happen. So just remember shock index. It's a useful tool in the emergency room. If you see somebody that's a trauma patient with a shock index more than 1, you should act quickly and figure out what's going on. The concept of C before A, we talked about this a little bit last time, but I'll kind of just hammer the point away again, is if somebody comes in and they have, catastrophic bleeding, the traditional A, B, C, D, E of the primary survey, where we start with airway and we make sure the airway is good, and then breathing and then circulation, you need to flip it a little bit. Because if they have catastrophic hemorrhage, let's say from a femoral injury and their femoral arteries bleeding out, if you don't control that bleeding, they're going to die. And it doesn't matter whether or not their airway is controlled. Also, if their airways, if you're paying attention to the airway and the breathing, but in the meantime, they're bleeding out or they've lost catastrophic hemorrhage and you have no IV access, this is going to be a problem because if you can't give them blood quickly, that you're not going to be able to resuscitate that patient. So just keep this concept in mind in cases where you have catastrophic hemorrhage. You want to first control this hemorrhage, either direct pressure, packing tourniquets. Obviously Roboa is something that's used in some trauma centers, but you have to be able to stem the hemorrhage somehow. And then circulation, restoration, IV fluids or IVs, and then giving blood components. And then you move on to airway management. So that's just a reminder of those concepts there. When we talk about controlling hemorrhage and hemorrhage control, there's 3 phases where this plays in when you're dealing with a trauma patient. So the different phases where we can affect and help the patient are essentially pre-hospital, before they arrive at the hospital, in the trauma bay or the ER or resuscitation area. And then definitive care would be when concepts when they go to the OR, when they go to the ICU, or they go to if available, interventional radiology to get embolization, for example. These are kind of the three phases. So pre-hospital, the things you can do here is, if you have EMS or ambulance personnel, their education, their training, we'll talk about that, shortening the time it takes to get the patient to the hospital. Trauma-based resuscitation is the concepts of, for example, C before A, like we talked about, and doing your ATLS and primary survey. And then definitive care is obviously like operative techniques and doing the right management for the patient. Again, when we talk about pre-hospital things we can control, so that's dependent on EMS capabilities. So getting to the trauma center as quickly as possible, controlling hemorrhage. Some EMS can give blood if they have blood available. That's helpful. Getting IV access before the patient gets to the hospital. In Palestine, especially in Gaza, this is basically destroyed. So the EMS capabilities are near zero. So the public also has a role in pre-hospital, or anyone with access to that injured patient, anyone who's going to get that patient, they can play a role in hemorrhage control. And that's kind of what some part of my lecture will be talking about. And then see, before we talked about this is more like when they get to the hospital, you want to control compressive massive hemorrhage with direct pressure or a tourniquet, get IV access, start massive transfusion, and then get them to the operating room as quickly as possible. We're talking about, this is massive hemorrhage, patients in severe hemorrhagic shock. Because we know, and the literature shows this many times, that delaying hemorrhage control, whether it's in the OR or interventional radiology, equals higher mortality. And 20 to 40% of post-admission death and trauma is related to massive hemorrhage. So you have to stop massive hemorrhage as quickly as possible. There's no substitute for quick control, because let's say you have a lot of blood products, but you're just giving it to them. If they're continuing to bleed, you're not solving the problem. You're just wasting resources, and the patient's not going to do well because they're continually bleeding. So in hospital concepts, we discussed in previous lectures, ATLS, so A, B, C, D, E. Of course, remembering circulation before airway in cases of exsanguinating hemorrhage. Getting good IV access. Classically, we teach using 2 large bore IVs, which is like a 16 gauge or an 18 gauge in the antecubital fossa, like right here, big IVs that can be, used to give transfusion rapidly. And then there's this concept in trauma of hemostatic resuscitation. This concept itself is a lecture by itself, many lectures and many chapters and papers have been written about this. But this lecture is just, I want to just introduce these concepts, and hopefully, whatever piques your interest, you can go and look them up and study them, because these are very important concepts in trauma surgery. So hemostatic resuscitation is basically when you're massively transfusing a patient, so you're giving them lots of blood. Blood is components, right? So component therapy is, there's packed red blood cells, there's plasma, which is fresh frozen plasma, FFP, and there's platelets. Those are the 3 main components of blood. If you're massively transfusing that patient, they're getting many units, let's say more than 6 or 8 units of blood. You want to make sure that you're giving, along with that blood, you want to give FFP and platelets so that they have a ratio close to 1 to 1 to 1. Obviously, this is based on availability, right? This is very resource dependent. But studies show that when patients get these blood products in a ratio close to 1 to 1 to 1, they have better outcomes. And that's because it helps with the coagulopathy of losing a lot of blood. Really, if you think about it, what we're mimicking here with component therapy, we're mimicking whole blood. Obviously, whole blood, which is blood like fresh out of the body, has platelets, has clotting factors like plasma, and it has red blood cells. The next best thing is to give the patient 1 to 1 to 1. So hopefully that makes sense. And I would invite you to do a literature search on this topic. There's lots of good literature, especially by doctors like John Holcomb, This is a very important concept in trauma surgeries, hemostatic resuscitation. Like if you're resuscitating, massively transfusing someone, you don't want to give them 15 units of blood and like 2 units of FFP and no platelets. That's not doing the patient any good because they need those clotting factors. They need those platelets as well. And then, of course, one of equally as important, maybe more important, is getting definitive hemorrhage control quickly. If you have interventional radiology, let's say it's a bad pelvic injury with extravasation on a CT scan, getting them to someone that can embolize that bleeding in the pelvis. If not, that's not available, getting them to a surgeon that can, let's say, pack the pelvis or take out the spleen or fix the blood vessel or whatever is injured that's causing the patient to hemorrhage massively. We talk about pre-hospital, and this is kind of what I wanted to focus on this talk, is utilizing and educating the public. So in the United States, the American College of Surgeons has a course called Stop the Bleed. And this is a course that's healthcare providers give to the public. We go to schools, libraries, universities, um, uh, places where there's a large gathering of people, and you can put on these courses through the American College of Surgeons, Stop the Bleed course, and you teach them the basic concepts of hemorrhage control. Unfortunately, in the United States, there's lots of mass shootings and mass casualty things, unfortunately. So this was basically created to try to empower the public that when a situation like this occurs, that the public can help because in previous events, situations, they've seen that some people died from preventable injuries. Let's say they had a gunshot wound to the femoral artery or to the leg or to the arm, and that bleeding wasn't controlled on the scene. And then by the time the scene was made safe and the patient was brought to the hospital, the patient had already died. So this idea was to teach the public these concepts so that the immediate responder, the civilian bystander who's present at the scene, can perform external bleeding control. And I'm going to talk a little bit about that because my hope is, obviously, I'm not giving an official course, but I want to just teach some of the concepts that from this course so that you guys can know them and hopefully pass the knowledge around. So they typically say, in the Stop the Bleed course, when they teach it to the public, they say, why is this important? Because somebody can die from bleeding to death within minutes. And then in the United States, the average time for EMS response is 7 to 10 minutes. And if it's an unsafe environment, it's going to be longer than that. And trauma-related deaths from bleeding is very high. So this knowledge is very important. And furthermore, why are these concepts important in Palestine? Because the challenges from pre-hospital care, whether in Gaza or the West Bank, are very unique in the world. There's great difficulty in accessing the healthcare system. It takes time sometimes to bring a bleeding patient to a hospital. Unfortunately, there are situations now, as in the past as well, of mass casualty events are becoming more common. And then there's a targeting of the healthcare system. So the healthcare system itself is diminished and then many times destroyed. So the public needs to be empowered with these just basic knowledge that they can help in those situations to save their own life or maybe help them save a life. And you guys as healthcare professionals and your training, this is a duty and a responsibility on yourself to learn these basic concepts and to teach them to the public, your communities, your family members, your friends, that hopefully this can, be helpful for them. The tab just got in the way of my slide. I'm trying to move it. Give me one second. I'll just keep going. All right. So these concepts is, when we teach this course, we try to make the concepts very basic so that somebody who has no medical knowledge is able to understand it, right? Because what may seem basic or intuitive for us as healthcare providers is not obvious to someone who's not in medicine or not in healthcare. So you want to, teach that the number one cause of preventable death after injury is bleeding. And the key points here is teaching people to identify life-threatening bleeding, and then stopping the bleeding by either pressure, packing, or a tourniquet. And I'll kind of go over tourniquets in a little bit. And so typically we teach like the ABCs of bleeding control. So ABC, A, alert. So you want to call for help. As you're going to the victim, you call for help, you alert people. Somebody calls an ambulance. B is bleeding, teaching how to recognize life-threatening bleeding. And then C stands for compress, which is getting control of the bleeding. And I'll go over some of those concepts. And then, when you're teaching people, you have to teach them these concepts as well. So calling for help, of course, you have to ensure your own safety. It's important to know your location so people can find you. And then call for help, either using a phone or someone around, like shouting somebody down to tell them that you're going to help somebody. When we talk about bleeding for B, you want to find the source of bleeding. So it's important to, this is kind of important to teach people, because for them, a little blood may seem like a lot, and it's how do you teach someone who doesn't know is not in the medical field, what life-threatening bleeding is? So you have to describe it in ways that they can understand. So bleeding that's continuous, bleeding that's large volume, like gushing out. If there's a large pool of blood, it's important to teach them that clothing can hide sources of continuous bleeding. And then it's important to teach them that multiple places can be bleeding, especially in a polytraumatically injured patient. When we teach about bleeding, we teach people, you can bleed from your extremities, from your legs, from your arms. You can bleed from these junctional areas, which is basically the armpits and the groins and the neck. And then you can bleed from, intra-abdominal or intrathoracic. This is the torso. So, typically we say the limbs, you can hold pressure, but you tourniquet the limbs and then you pack the junctions, which is like the neck, or you hold pressure on the junctions, neck, armpits, groins. And then the torso, they say seal the box. It means covering it and sealing it. But really, if somebody's having intra-thoracic or intra-abdominal bleeding, there's not much you can do pre-hospital. You need to just get them to the hospital as quickly as possible. Junctional anatomy, these areas like the neck, any injury that's bleeding to the neck, to the axilla, where your axillary artery is, and the vein, to the femoral area, where femoral artery and vein, these are large blood vessels in these areas. Patients can exsanguinate within less than a minute from these areas. So it's important to teach holding pressure on these areas. And if it's a large wound and pressure is not working, try packing it. And we'll talk about packing in a second. But these areas need pressure and packing compression to hopefully stop the bleeding there. And then when you're teaching these concepts, you teach people when they hold pressure on something or they pack a wound that they don't let go. They stay there until they can get to the hospital. Because what can happen is if they do it and they let go, obviously they bleed out. But again, these may seem like very basic concepts to us, but it's important that we teach people this, because someone, again, not in medicine, they're not going to know these things. So when we go on to C, so compress, you teach applying direct pressure to the wound, focus on the area of bleeding, use only enough gauze or clothing or cloth to cover the injury, and then keep pressure until the bleeding stops and hold pressure until help arrives. So like when we give this course, we have these little dummies or whatever that we can teach this. So it's, we show them the injury, and this is like a interactive course. So it's like hands-on basically. But you want to show people, like if something's bleeding here, you want to use firm pressure with all your fingers. Sometimes you need two hands, and then you press down with both hands, like sitting up until the bleeding stops. And then the other concept, like, a lot of times you see wounds, especially in the ER, they come in, people put a lot of gauze on it and they're just holding the gauze. You have to teach them that this isn't doing anything, because a lot of times the blood soaks into the gauze and it drips out. So if you're holding pressure on like a punctate wound, for example, You don't need a lot of gauze. You just need a little like ball of gauze, for example. But the most important thing is direct pressure down onto the wound until the bleeding stops. And you want to teach them like you want to make sure you're not seeing blood coming from around that wound. So hopefully that, that makes sense to you guys. When we talk about packing a wound, so packing a wound is for larger wounds, larger soft tissue injuries. So if there's a big wound that's bleeding and just holding pressure is not going to be enough for this very large wound, you want to teach people how to pack a wound with either gauze or cloth or whatever is available that you can pack inside the wound, and then after that you hold pressure. So like in the same um, kind of model I have here. So you go around, you teach people how to pack a wound, and you teach them to pack in very tight and pack it in deep first, and then you keep packing until you can't pack the wound anymore, and then you teach them hold pressure, two hands very tight until you don't see any bleeding anywhere. Anyway, so this can be helpful anywhere in the body. Um, and here in this diagram, you can see, the important concept here is when you're packing a wound, that whatever you're using to pack it goes in deep first, then superficial, so the whole wound is packed, as opposed to just putting something on the outside that's not going to do anything. And then, when we talk about tourniquets, this is obviously dependent on availability of the tourniquets. But like for example, one of the pushes, I'll go back here just to show a picture of it. One of the pushes was like you see in the United States, there's these AEDs in a lot of facilities where they have to have these defibrillators around in case someone's heart stops to give them a shock. One of the hopes was in these same kits to put a kit for hemorrhage control where tourniquet will be, inside that kit. And so, that the people in the public may have access to it. But, like, for example, in my car, I have a kit that I made and it has a tourniquet and other stuff in case, I come onto an accident or something like that. I can, use it if need be, if there's no EMS or ambulance there. But just to go over the tourniquet, this is a basic tourniquet. Tourniquet is like basically something that you tighten it and it stops the bleeding. And it has usually Velcro on one side. So I'm gonna back the screen up so I can show you guys. Has anybody here used a tourniquet or is familiar with tourniquet? Maybe put something in the chat so we can see. But you want to tighten it here. Let's say I'm putting it on myself. You want to put it high above the injury. So let's say my injury is at my elbow. I want to make sure the tourniquet's as high as possible. And then you just tighten it as much as you can, and you wrap it all the way around the Velcro. And then there's something here. This is called a windlass. So this has to, once it's as tight as possible with the Velcro, you tighten your windlass very, very tight until the bleeding stops. And if the patient's conscious, a lot of times they'll tell you like they're in pain because it hurts, and that's okay, because if they're bleeding to death, they need this tourniquet. And then there's a little slot here. You take the Velcro off. I'm doing it on myself, so it's not as smooth, but and you slide the windlass in it to hold it in place. And then you put the Velcro, and if you should write the time there so people know how long the tourniquet's been on. So it's important to know how to put a tourniquet on and teach people how to place the tourniquet. And that's part of this class is basically, this class is on, we teach people how to practice putting tourniquets on each other, how to practice putting it in the arms, putting it on the thighs, on the leg. But so the tourniquet needs to be tight. If the tourniquet's on and they're still bleeding, that means it's not tight enough. So first you have to tighten it all the way, then pull the Velcro over, and then you tighten it until it hurts. And then importantly, you have to see that there's no bleeding. If the bleeding has stopped, then you know the tourniquet's on tight enough. The question becomes like, let's say you don't have a tourniquet, all right? So when I was in Gaza, for example, I saw people using like string, like rope and string. That you have to use whatever you can get, unfortunately. So if you have, let's say, a belt can work, but the important thing is it has to be tight enough that it's stopping the bleeding, right? If you use a very narrow rope, for example, it may cut into the tissue without stopping it, providing enough pressure to stop the bleeding. So, like, you want something that's gonna have some thickness to it, like width, so that it can provide pressure. And if this is not available or you can't, let's just hold pressure. I mean, if you can hold pressure, then that's enough. But the problem is when you're holding pressure, now you're stuck holding pressure. You can't do anything else. You can't help somebody else. You can't go somewhere else. You can't carry the patient. So if you have multiple people, holding pressure may work. Um, and then the other concept is the tourniquets only, again, for the extremities. If somebody has a neck wound, you have to just hold pressure on the neck wound. There's nothing else you can do there. If someone has a groin or an axillary injury, you have to just hold pressure. If there's something on the extremity that's exsanguinating, like very brisk bleeding, then if you have a tourniquet, use a tourniquet. If not, just hold pressure. And then the time is important. Writing the time is important because obviously, if you put a tourniquet on, now you've cut off the blood supply to that limb. If the hospital or definitive care is going to be hours and hours away, they may lose that limb. So that's an important concept. Before, classically, uh, back like in the Vietnam War, as an example, tourniquets were kind of discouraged in the public because people were afraid, you put a tourniquet on, they can lose their limb. But now they've kind of resurged because when these mass casualty situations happen and people die from their injuries to the extremities, these are survivable injuries. We're not talking about, putting a tourniquet on something that's like minor bleeding that could stop with just a wrap, you know, around the arm. That's not what we're talking about. We're talking about somebody with a big explosive injury that's bleeding out, somebody with a gunshot wound, and there's clearly a vessel that's bleeding. If this patient, you can get them to the hospital 30 minutes to an hour, put the tourniquet on, and you save their life. You don't want is them dying from a survivable extremity wound because the key here is preventing, is saving a life for preventable death, right? So I hope that makes sense. All right, let's see. And then if you go on the Stop the Bleed website, stopthebleed.org, they have some free resources you guys can use. These are like posters, so you can print this out, you can put it in your hospitals and your school, wherever. These are kind of the basic concepts we teach people: applying pressure with hands to stop the bleeding. If it's a big wound, packing the wound and then compression, and then how to, applying a tourniquet properly, and writing the time, and then of course getting them to the hospital as quickly as possible, right? Then again, here's like another poster that's on their website. But for first step, ensuring your safety, uh, looking for life-threatening bleeding. And then, obviously, if a trauma kit's available, you can use a trauma kit. If not, use any cloth or apply steady direct pressure directly on the wound. If you have, let's say, a tourniquet, you have things, the question becomes, where's the wound? Arm and leg. If the tourniquet's available and it's severe bleeding, put the tourniquet, tighten until the bleeding stops, get them to the hospital as quickly as possible. If we're talking about junctional areas like neck, groin or shoulder, axilla, packing the wound and holding steady pressure. These are available on their website. This is another thing I found on Google, kind of helpful. Same thing. Where's the wound? Is it a junctional area, neck, shoulder, groin, or arm or leg? If you have a tourniquet, you can use a tourniquet for the extremity. If not, pack the wound or hold pressure, right? And then they have these kits available online, but you can make your own kit. Just put like gloves in it, put some gauze, put some wrapping like Curlex, or I think you guys call it like crib bandage. um Put tourniquet in it if you can get a tourniquet. Put some shears like to clothing, trauma shears, a blanket, a little marker, uh, you know put one of these in your car or in a bus or whatever. It's it can save somebody's life. So again, the Stop the Bleed website's helpful. If you go on YouTube or on Google and search Stop the Bleed or stop, um, hemorrhage control type things, there's lots of resources online. So, my goal hopefully with this is, in these difficult times, just kind of teach some of these concepts to you. And then I'm hoping that, inshallah, one day I can come and teach this class there with the American College of Surgeons. But if not, I want these concepts to be hopefully spread by you guys, and teaching your family and friends and your community back home. And hopefully this information is life saving. So if anybody has any questions, please ask. But otherwise, that's all I have.
Jazakallah khair, Dr. Amer. I think, like you said, it's so important that we're doing this sort of teaching and then it's also being propagated again and again. If anyone has any questions but wants to maybe send them later or send them to me on PM, let me know and I'll forward them. But yeah, Jazakallah khair. Thank you so much for your time today.
You're very welcome. Assalamu alaikum.
Assalamu alaikum.